this video message find you all doing okay. This is block 2 for section 3, the wrap up of the upper extremity. And this week our focus was on shoulder disorders. Now, I hope you guys are all doing well. I realize that this has just been a very trying time for a lot of people, and I'm sure that a lot of people are in very difficult situations. This is probably unlike any, I know this is unlike anything you've ever experienced, and I'm sure that your clinics are all struggling to find work and to appropriately keep you busy. I know in my clinics we're working hard to do these virtual visits or video visits via telehealth options. And while things are rolling forward, it's certainly a trying time to integrate new technology, scheduling, and all of these other things, building out work standards. And it's not easy. This is somewhat heavy lifting in a rather short amount of time to try to keep people working, essentially. And so I know that feeling, and I'm sure every day is a different experience for a lot of people. And I'm sure there are people who are working in hospitals that are doing things that they have never done before, or maybe going into labor pools and working long hours into the evening. So again, I understand that these are trying times. I would just ask that all of you, if there are issues around this and taking the course, that you reach out to me so that we can make the necessary accommodations. But I can't help if I don't know. So if there's anybody out there who needs something, please let me know. All right, on to the Block 2 wrap up. So Block 2 take homes. There's some really good discussions about many different topics related to the shoulder. It really was all about, a lot of stuff was just based about a lot of discussion was based on the Missionary McClure article. That's just, I really feel like we need to continue to, I'll talk more about my opinions of where we're at the shoulder, but a lot of good discussions about the shoulder, this idea of pathoanatomical approach versus kind of a staged approach. Where we improve on that, where we go, how do we get there, what value does pathoanatomical structures play for us and the work we do with our patients. A lot of thoughtful approach when it comes to SINS and how they impact care for both shoulder and elbow. So whether that be the patient case, who everybody recognized was low irritability, how everybody recognized that you could push this person, but also when talking about doing a shoulder examination, how do you get them to move forward? How hard do you push? How aggressive is your examination? Can it be? And then speaking to irritability, and then talking to the patient about what these things mean. Great stuff about how we approach our patients to get good clinical information, right? A lot of discussion about how we engage our patient, how we try to gain valuable information when we're screening through this process. I want to tell you all to continue. I think it's really easy to fall back on what we've seen clinically. There's absolutely nothing wrong with that. But I want to continue to stress to you is the importance of finding literature to help support your ideas, your thoughts, what you think, draw on those. And also like compare and contrast your thoughts. Well, I believe this to be true, and then go find literature to either support that or say, gosh, my logic is somewhat okay, but perhaps could be better because the literature doesn't really support that. There's a couple examples of that. So again, continue to do that. I'm going to now kind of go through what I think, how the Missionary McClure article should be used, and where we just are not, where we could be better. And this could be true for lots of areas of our profession where we need to be better. What we know and what we don't know is still quite a chasm, if you ask me. Okay, so everybody really understood this concept of, that they're totally cool with this idea. We're going to screen through that level 1 screening. Again, don't forget about red and yellow flags. Really important. Then we flipped into the examination. Now, this is where we started to, or I would say we would start to push back. There were some concepts about special tests and the use of special tests, and are special tests valuable? Do they need to be used? And do those special tests speak to the specificity of pathoanatomical diagnosis? It is my opinion that you can do impingement testing, but it really doesn't tell you much about what's happening outside of it. Speaks to irritability, right? So if somebody does a cross-body test, an empty can test, a crank test, It doesn't tell you if the bursa is involved. It doesn't tell you if you're impinging on the rotator cuff. It doesn't tell you if the subacromial space has a spur in it. It tells you that there's irritability within the shoulder joint, and that's all it does. There's a number of articles that basically say we impinge all the time for lots of people, and there's no pain. So this concept because I was raised under the concept, or I've educated under the concept that there was this hood, and if the cuff was strong, and if there was no bony spurs or no arthritic changes, that there was this nice amount of space, and the joint moved freely within that space. And the reality of it is that's not true. The reality of it is that we are impinging all the time. And so when we use these, so can you use special tests? Sure. Do they tell you something pathoanatomical? No, they just speak to irritability. No more than a end range overpressure would of a shoulder flexion moment or a shoulder abduction moment. Or if you couldn't get to end range, just a point and a painful arc, if you will. But they don't really speak much more than that. So again, making this we need to do better when it comes to taking any kind of our examination and tying those to pathoanatomical, because it really probably has nothing to do with that and speaks more to irritability. And it might also speak to why we get why we can see change in rotator cuff presentation just by doing some thoracic manipulations and then giving them some exercises. Okay. All right, let's go to the next slide. So when in the Michelin-McClure article, they subgroup people into these 4 categories. And I think everybody agrees that it's a stiff shoulder is not hard to diagnose. Although I would argue I've had some kind of, what do you say, adhesive stiff shoulder light. And then you ask yourself, is this really adhesive capsulitis? Does it really follow that same pattern? Because there's new research that shows adhesive capsulitis has a lot to do with muscle guarding. I posted a video clip to Eddie's, some of the discussion I had with Eddie, and a video clip about a great article by, I believe, Hollmann, Hollmann, et al., who they did this most recent study, I believe 2019, where they videotaped these people they were going to manipulate under anesthesia, and they found that they had complete passive range of motion. So are they dealing with muscle guarding? There's research that talks about stiff shoulders being a metabolic disorder. So there's some literature that uses neurodynamics to treat the irritability, some dry needling. That would probably lie more within that muscle stiffness. We don't really know. We know glenohumeral instability, or this kind of loose shoulder, or a shoulder that has a lot of motion but gets pain with maybe some specific reaching. We have these categories. How well tested are these categories? They haven't been. The subacromial pain syndrome category, right? That's the classic. Boy, that's a real classic. It's got a whole bunch of things in it, right? From rotator cuff tendinopathy to tears to impingement problems to, but why couldn't that just be an irritability, subacromial irritability? I would probably lean more on that. And then we've got this other common diagnoses. What we need to do is we need to have studies that look at each of these categories and look at them more closely and find more common denominators that we don't have, okay? So we need to build on that, because in my opinion, the shoulder is really no better than low back pain as far as specificity goes. We used to talk about different kinds of low back pain, and we know that there are, much like in the shoulder, there could be a couple of different categories. They're very vague in their presentation. We think more in the lumbar spine. We look more at how treatments affect different presentations, and maybe that's where we're going to have to go with the shoulder. And and then we haven't even talked about these kind of scapular dynamics, and this idea that we can that there is some kind of, that there is scapular weakness, and I firmly believe that plays into it, but we have no way of assessing it. Visually doesn't work. Simple shoulder exam doesn't work. We need to know more information that we just don't have. And so again, I love what I do, and I think there's a really great way to treat shoulders, and it's basically making them stronger. In the case of subacromial pain and glenohumeral instability, and with adhesive capsulitis, it's about making them more mobile, right? And then perhaps adding some strength to help with that. I oftentimes think that maybe I'm underloading people with adhesive capsulitis, but that's in my mind, one of the key differentiators for adhesive capsulitis. They have really good strength, at least in manual muscle testing. And then you could make the argument that what does manual muscle testing really tell us? Because we don't have any kind of frank weakness, and that was really not meant for tweaking kind of very vague weakness or deconditioned shoulder. But anyways, the point being is that we've got a long way to go with this, and there's a lot more questions than there are answers. And so if you are confused about the shoulder, that's okay. But I do believe that if you use this, it's a pretty good way of looking at the shoulder. And if you speak about irritability to the patient and you speak less about pathoanatomical diagnoses, I think you're better off, because I think you can give patients hope. We know that rotator cuff repairs, or rather rotator cuff tears, do well with load, especially if they're degenerative tears, and this has been a progressive thing. The traumatic ones are a little bit different. They seem to not respond as well, and maybe they're a better candidate for surgery. But this idea that somebody comes into an orthopedic clinic and says, I have shoulder pain and I'm 70 years old, they do an MRI and they're like, oh, look, you've got a tear here, we should operate. That's insanity, okay? I'll leave it at that. And now in regards to the case, again, I kind of mentioned the case. Everybody did really well with that, so I'm not going to spend a ton of time on that. But I will say that, people's hypotheses were pretty spot on. It would be my opinion, I'll just give you my opinion, that this dude has, the dude's shoulder is weak, and that resulted in his ECRB and the muscles around his forearm to work harder. And they couldn't hack it. And if he had a stronger shoulder, if he would have been stronger more proximally, then distally his elbow wouldn't have been bothering him. That's my 2 cents, what is going on. And so yeah, I'll leave it at that. Okay, so as we move forward, you're going to get feedback as we hit the halfway point. We're going to get new groups for the second half, so be on the lookout for that. Block 3 is wrist, elbow, and the physical examination for the case study. So there's going to be some really good stuff. So we're going to dig into now the elbow. Well, so we've done a really good job of kind of, yes, this is elbow. Yes, it's probably more of a tendinopathy kind of irritation, or we're going to figure out in the physical examination what that is, and then we're going to figure out how to treat it. Again, reach out with any concerns. I realize that you are all under varied stress levels, and some of them are quite high, and perhaps more than some, perhaps all are quite high as a result of what is happening currently. So if there's things that aren't going the way you planned, then please just reach out to me so that I can help with this, okay? And again, you can call me, text me, email me, whatever works best for you. I really enjoyed some of the discussions for Block 2. I thought some of you guys did a really good job of digging in and really being thoughtful, and some of the responses to me were really thoughtful as well. And I hope I provided challenging questions and engaging conversation, because I really enjoy the banter. And so, if I get a chance, if in responding to me, you ask me more questions or challenge me more, I look forward to reading those again and coming back at you. That is, and I hope you look forward to coming back at me or challenging me, engaging me. Because I enjoy the banter. I enjoy sharing the literature that I have. I enjoy questioning my own ideas and your ideas, because that's how we get better, by questioning. So I hope you all take good care, and I look forward to reading what you have to say about Block 3. Again, reach out if there's any issues that you feel are out of your control and you would like some help with, as far as more time or some accommodations, or even I've had certainly people come and say, I need to put this course on hold because. And I totally get that too. So hope you all have a reduced stress weekend, and I wish you all the best in the coming weeks.